Good morning, everyone, and welcome to another Ground Rounds. Today, we're continuing on our theme of infectious disease. Last week, we spoke about all the infections in HIV patients and opportunistic infections in HIV patients. And today, we have Dr. Chua with us to discuss histoplasmosis. Dr. Chua is an infectious disease specialist from Southern Illinois University School of Medicine, where she's also the assistant professor of clinical internal medicine. After completing her medical education in the Philippines, she completed her residency and fellowship also at SIU Med and continues to strengthen the medical learning that happens there as an educator. So we're very, very excited to have you here today. And without taking too much of your time, I hand the mic over to you, Dr. Chua. Thank you again for being here.
Thank you for that introduction, Prinity. I hope I said it right. Yeah, and it's a pleasure to present a lecture today about histoplasmosis. I just wanted to make sure that everyone could see the screen correctly.
Yes.
Is it visible, Prinity? Great. Yeah. So
yes, and it's big screen.
All right, so let's talk about histoplasmosis. But before I proceed, I just want to say I have no financial interests or relationships to disclose. Our objectives today really is just more the basics of histoplasmosis. So definition, epidemiology, the mycology of it, the spectrum of disease, diagnosis, and therapeutic modalities, prevention of histoplasmosis as well. So histoplasmosis is caused by a fungus called Histoplasma capsulatum, and it's usually primarily acquired through inhalation of the mycelial fragments and microconidia. Usually when one gets infected with histoplasmosis, it would result in an often self-limiting disease. But if you are someone with immunocompromised or someone with an immunocompromised host or other pre-existing conditions, this infection can turn potentially lethal. Disease trend, unfortunately, for histoplasmosis is unlikely to abate, mostly because the reservoir of the fungus is the soil, and we can never get rid of that. And histoplasma, as a fungus, really thrives on acidic, nitrogen-rich, and moist soil, which is why it's usually associated, or you see it in bird droppings and in bat guano. Usually how someone gets histoplasmosis or inhales histoplasma is through the disruption of soil, either by excavation or construction. And that's really how you release the infection elements that you eventually inhale and settle into the lungs. So people who are at risk for this are your spelunkers who roam caves where the bats reside, those who are engaged in agriculture, your farmers, people who work in outdoor construction, or those who work doing rehabilitation of buildings that have been inhabited previously by either birds or bats. Human-to-human transmission via the pulmonary route has not been reported, but cutaneous inoculation or transfer with allograft can occur, although that's rare. And then transplacental transmission can also occur, but again, that is very rare. Histoplasmosis in the USA is endemic really in the Midwest and South Central part of the United States, so the Mississippi and Ohio River Valley regions. It's more widely distributed though, so it's more widely distributed than what scientists think, because actually it's reported around the world, not just in the US. And they particularly thrive in humid areas. So worldwide, as you can see, those that are shaded very dark purple are those where they are hyper endemic, and then in other in the light purple areas are those with reports of locally acquired cases. Essentially, in every continent in the world, there has been or there have been reports of histoplasmosis, except for Antarctica. So again, while histoplasmosis, when you read your textbooks, they all say United States, Mississippi, Ohio River Valley. Really, you can see it in almost, in a lot, worldwide, essentially. So let's proceed to the mycology of, this disease. So Histoplasma capsulatum is a member of the family of Ascomycetes. There are two morphotypes. So this is a dimorphic fungi. There's the mycelial phase, which is the saprobic phase, and the yeast phase. So your mycelial phase, which is on the upper left side of that screen, that is the one that thrives in ambient temperature. That's the mycelial phase. And then the yeast phase, the one on the bottom, does thrive, or is how it presents when it's 37 degrees or essentially body temperature or higher. So the microscopic evaluation of the mycelial phase will reveal two types of conidia, which you will see on the right. So you have your macroconidia, which is the one that's labeled A. And they are large ovoid bodies that span 8 to 15 micrometers in diameter. It's not slender, but it has protrusions that are referred to as tuberculate. And then you also have your microconidia, which are smaller. Of course, they're microconidia. And these are actually the ones that are believed to be the infective phase, because their size is small enough to lodge into your terminal bronchioles and alveoli. So really for, the most critical determinant in the establishment of the infection is the transition from the mycelial or the saprobic phase to the yeast phase. So your mycelial, your microconidia, to the yeast phase is what, that's the transition that needs to happen for, for infection to establish infection. So after your conidia, your microconidia settle into the alveoli. They are engulfed by neutrophils and your macrophages, and then that transition or that conversion happens intracellularly and can happen from anywhere between from hours to days. And then once they're intracellular or in your cell, they will then migrate to local draining lymph nodes and subsequently to distant organs rich in mononuclear phagocytes like your liver and your spleen. So, our body, we have our own, ways of trying to avoid these kinds of infections. So your immunity, you have your innate and your adaptive immunity. For your innate immunity, the things that you have to fight against infections like histoplasma, one are your neutrophils. So the granules in your neutrophils, they do have defensins as well that exhibit fungistatic activity. And then you have your macrophages, and how histoplasma is phagocytosed by your macrophages is facilitated by your CD11 and CD18 receptor. And then once your macrophages engulf, the histoplasma, the yeast cells, would be located within the phagolysosomes. However, these yeasts survive even in this hostile environment. By that I mean the phagolysosome. They are able to survive through the alkalinization of that compartment. So it's still able to evade at some extent, your innate immunity. And then for your adaptive immunity, really T cells are very pivotal in the clearance of the fungus through the release of cytokines, interferon gamma, interleukin 12, and your tumor necrosis factor alpha that eventually activate your mononuclear cells. Although the infection is limited by your cell-mediated immunity, tissues really are not sterilized. And so infected cells that contain yeast, some of which can remain viable for many years, and then the dormant organisms really, they're just bystanders and they pose little risk unless in the future the individual becomes immunosuppressed, in which case that can become a problem. So really, the hallmark of tissue response to the fungus is the formation of your caseating or non-caseating granulomas, an example of which you will see on the right on that photo there. And your granuloma really consists of an admixture of your mononuclear phagocytes and lymphocytes, principally your T cells. And really the function of that granuloma is to contain fungal growth. Organized granulomatous inflammation is typically observed in self-limited disease. So if your immunity is intact and you're able to limit the infection, then you will form organized granulomas. However, in progressive disseminated histoplasmosis, you have the reverse of that. So the more common histopathologic appearance of tissue is with a massive influx of macrophages with scattered lymphocytes, so you don't see granulomas very well. So this is just something to show us that really histoplasmosis is a spectrum of disease. And we'll talk about that a little bit more, but it can range from asymptomatic to acute, chronic, and then disseminated disease. So let's start with acute infection. So the acute primary infection, so a majority of these infections go unrecognized medically. Either your patient is asymptomatic or they only have a mild flu-like illness that goes away on its own, so much so that they don't really seek care. The major determinant for the development of symptoms, though, in acute infections with histo is likely to be the inoculum size. And other factors include your age. So any less than 2 years old or more than 60 years of age, and any other underlying diseases that your patient might have. For acute primary infection, the incubation time is usually 7 to 21 days. And even if your patient does present with symptoms, usually they will resolve within 10 days. But if there is heavy inoculum exposure, that can persist for several weeks. And these kinds, acute primary infection can be accompanied by rheumatologic manifestations like arthralgia, erythema nodosum, and erythema multiforme, most of which are actually seen in women. For acute infections, your physical findings will usually be minimal, but you can hear auscultation. Rarely you will see hepatosplenomegaly. And on your chest x-ray, you'll see that your patient has a patchy pneumonitis that eventually calcifies, and they will have hydrolymphadenopathy. They can have what's called a buckshot appearance, especially with a large inoculum exposure. Pleural effusions are uncommon. It's very, not very helpful because your patients with active pulmonary histoplasmosis, usually their white count or leukocyte count is usually actually within the normal range. And even if they were abnormal, they could skew either the side of leukocytosis or leukopenia. So your leukocyte count really isn't that much of a help in this kind of a stage of disease. You may also see transient increases in serum alkaline phosphatase level, but again, that's very vague. In acute infections, you can also have pericarditis, but it only occurs in about 6% of those who acquire histoplasmosis. And those will usually have a high proportion reporting a respiratory illness 6 weeks before the onset of pericarditis. And it's really not caused by the direct invasion of the organism itself, but really by the granulomatous inflammatory response that is mounted against the fungus in your mediastinal lymph nodes that's adjacent to the pericardium. Another is acute reinfection. So with acute reinfection, like the name suggests, you have repeat exposure to the histoplasma. and with re-exposure to a large inoculum that can present with, like again, a milder influenza-like illness, but the onset can begin within 3 days, which is much shorter than your primary infection. And on your chest x-ray, you will see what they call miliary granulomatosis. So there are numerous small nodules that are diffusely scattered throughout both lung fields. Here, though, hilar or mediastinal lymphadenopathy is absent, and duration of illness is often briefer than in primary infection. Another presentation is what we call the histoplasmoma. So it resembles a fibroma, usually found in the lung, but instead of actually resolving, it continues to grow over years due to the persistent antigenic stimulus from yeasts. It's composed of active inflammation at the peripheral and fibrous tissue within the inner sphere. So that's the, on the right side with that photo, you see that on the left lower lung field, that there's that round lesion there. So that's the histoplasmoma that we were talking about. And then you can also have mediastinal granuloma and fibrosis. And so basically enlarged lymph nodes due to granulomatous inflammation. And this is troublesome in some ways because sometimes they can grow enough that they may impinge on your major airways. And then during the healing process, the fibrotic tissue can cause retraction of the airways. So your patients can get post-obstructive pneumonia, bronchiectasis, or they can cause constriction of the esophagus or the superior vena cava causing dysphagia and SVC syndrome. And then the other, as we progress from asymptomatic and then acute histoplasmosis, you have your chronic pulmonary histoplasmosis. And there are two kinds of that can be either cavitary, which is the more classic chronic pulmonary histoplasmosis we're used to. And then there's also a non-cavitary one. So for cavitary chronic pulmonary histoplasmosis, your patient will have a more insidious onset of symptoms. They'll present with low-grade fevers, productive cough, dyspnea, unintentional weight loss. And when you look at their radiograph, their radiographs, you will see patchy infiltrates, and that can develop into areas of dense consolidation that then progress to cavitation. And when they do cavitate, usually it'll happen in the upper lobes. And this can happen over months or years. There could be formation of extensive fibrosis, retraction, areas of compensatory emphysema appear unless effective treatment is given. Enlarged hilar or mediastinal lymph nodes are notably absent in chronic pulmonary histoplasmosis. Again, for your laboratory work, you can have leukocytosis, elevated alkaline phosphatase levels, but only in 1/3 of symptomatic patients. Anemia is present in half. And then for your non-cavitary pulmonary histoplasmosis, again, you have your fevers of, your symptoms of cough, weight loss, low-grade fever, and chills. Your patients can also present with arthralgias, fatigue, chest pain, but less than 50% of patients have that. And instead of cavitary changes on your radiographic examinations, you will see nodules, infiltrates, and lymphadenopathy. Less common but can happen are fibrosis, thickened pleura, and volume loss. The most striking differences really is that in those without cavities, positive cultures are highly unusual. So for progressive disseminated histoplasmosis, so this is the more severe end of that spectrum of histoplasmosis. So it refers to the relentless growth of the organism in multiple organ systems. So virtually any organ system can be affected. And its estimated incidence of 1 in 2,000 cases of histoplasmosis. And major risk factors, again, older age and immunosuppression. So for immunosuppression, that includes people who have AIDS and have a CD4 count of less than 150, and patients who have a history of use of TNF-alpha antagonists. So for progressive disseminated histoplasmosis, it's a spectrum in itself. There's an acute, subacute, and chronic form. So your acute form, as the name implies, it's associated with a fulminant course. So you have massive macrophage infiltration and scattered lymphocytes. Tissue macrophages are engorged with these cells. And when you test your patient for cellular immunity, often they will reveal poor to absent responses. So for your chronic form of this progressive disseminated histoplasmosis, you have, again, like the name suggests, an indolent course. And in this type, you will see presence of well-circumscribed granulomas in involved tissues. You will not, really see a lot of yeasts in tissues. And usually in these types of populations or affected individuals, you will have a delayed type hypersensitivity responses that are intact. So let's just go at it one by one. So again, for the acute progressive disseminated histoplasmosis, these occur in patients who are very or severely immunosuppressed. So those with AIDS, hematologic malignancies, and those who use TNF-alpha antagonists. Before the advent of, other immunosuppressive medications or biologics, TNF-alpha inhibitors, other immunosuppressive regimens. This was actually previously principally seen in infants. So that's why sometimes there was a moniker for it that they called it the infantile form of progressive disseminated histoplasmosis. And at that time, it was believed to be a progression of primary exposure or reinfection because pulmonary symptoms dominated early in the phase of illness. Abrupt onset of symptoms, fever, malaise, unintentional weight loss, cough, diarrhea can be seen. Physical findings, hepatosplenomegaly is a big thing that you will see in almost all patients. Lymphadenopathy, especially of the cervical chain, and then crackles. You can see jaundice and oropharyngeal ulcers in some, but not in a lot. For your lab findings, anemia in 90% of cases. There can also be leukopenia and thrombocytopenia. So essentially, your cytopenia of all cell lines can happen. Chest x-ray with patchy pneumatitis and chest lymphadenopathy can also be seen. And mortality is 100% when untreated. Mostly your patient's route of exit will be through the IC or GI hemorrhage because of severe thrombocytopenia, secondary bacterial sepsis due to profound granulocytopenia. So, it's a very severe infection. Progressive disseminated histoplasmosis and HIV. So there's it's an opportunistic infection, histoplasmosis. So in patients with AIDS or HIV with CD4 of less than 200, history of exposure to chicken coops, known positive serology for complement fixing antibodies before illness, those are high risks for PDH. Most patients, though, who do develop PDH have had at least one opportunistic infection. So, they've already established themselves as being immunocompromised, essentially. And 90% of them will present with fever and weight loss. Your common physical findings will include your RALs, hepatosplenomegaly, again, that's a big thing, and lymphadenopathy, usually of the cervical chain. But they can also have mucosal ulcers and cutaneous lesions, as you will see on the picture on your right. So this one was a maculopapular eruption, sometimes with crusting. You can also see petechiae or ecchymoses. Other unusual presentations include colonic masses, perianal ulcers, chorioretinitis, meningitis, and encephalitis. Histoplasmoma of the CNS and chronic meningitis are manifestations of a more indolent form of PDH. And then you have your subacute progressive disseminated histoplasmosis. So really compared to the acute, there's just more prolonged nature of symptoms before your patient seeks medical attention. They do present similarly, subjectively through your symptoms and your physical examinations in the form of hepatosplenomegaly and oropharyngeal ulcers. But the laboratory abnormalities are less striking than in acute PDH, where you would see, you can see pancytopenia, transaminitis, elevated alkaline phosphatase, etc. So here is just a little bit less striking than that. But one of the notable features of subacute PDH or progressive disseminated histoplasmosis is the presence of focal lesions in various organ systems, including the gastrointestinal tract, which is the most common. And usually if in the gastrointestinal tract, it will involve the ileum and cecum. It can also, you can also see these in endovascular structures, the central nervous system, and adrenal glands. So as for endovascular infections, that could be in the form of endocarditis, native valve, or prosthetic valve. For native valve, the aortic valve is the most commonly involved. And you can even have infected abdominal aneurysms or your mycotic aneurysms, and infection of prosthetic grafts. For CNS involvement, you have your chronic meningitis, which is most frequent. You can see mass lesions in the cerebrum. And then your CSF, you will have, when you tap your patient, you will see lymphocytic predominance, hypoglycemia, and elevated protein levels. Adrenal glands usually, when adrenal gland involvement is confirmed, it's usually, unfortunately, during autopsy. But really overt Addison's disease is uncommon, even if the adrenal glands are involved, occurring in less than 10% of patients. And then you have your chronic progressive disseminated histoplasmosis. So you distinguish that from subacute PDH by the prolonged chronicity of symptoms that are often mild. So it's seen almost exclusively in previously normal adults. And these patients, compared to your acute and subacute PDH, they won't present with low-grade fevers or chills or respiratory symptoms or weight loss. So what really they will present is with malaise and lethargy. So that's, those are their most frequent complaints. Again, fever is less frequent. And even if it does occur, it's usually low grade. Most common physical finding, though, is an oropharyngeal ulcer, an example of which you will see on the photo on your right. And it will present as a well-circumscribed, indurated, and usually deep and painless lesion. And this patient, it was found in the tongue. Another kind or another organ which histoplasmosis can infect is your eye. So ocular histoplasmosis, and there are again two forms of that. One that is associated with your active or your acute PDH, and that would present as uveitis or panophthalmitis. You will see granulomas in the uvea, and yeasts will actually be recoverable. And then one of the more common kinds is presumed ocular histoplasmosis syndrome, which presents as a posterior uveitis or choroiditis in individuals who manifest skin positivity to histoplasmin. They have these peripheral atrophic scars, or what they call histospots, and a lack of vitreous or anterior segment inflammation. So it's really relatively a benign disease, looks like, but the consequence really happens 10 to 20 years after the appearance of scars, and that's through neovascularization that can lead to loss of vision in up to 60% of patients. So if you have neovascularization, you're at risk too for macular hemorrhage, and then that's how you end up or your patients can end up losing their vision. Really, the first line treatment for this is more with anti-VEGF therapy or vascular endothelial growth factor therapy. The last I last time it was still quote off-label, but if you, based on the American Academy of Ophthalmology, they do recommend or they do consider that as first-line treatment. Other things that can be used to treat this, and again, only if there is already proof of neovascularization, is through photodynamic therapy, laser, intravitreal or systemic steroids. Really don't have that much evidence in terms of their efficacy. But I think that the most important thing to realize here is that for presumed ocular histoplasmosis syndrome, antifungal therapy really has no role in this. Antifungal therapy, systemic antifungal therapy, is not effective. And then there's also African histoplasmosis. So in Africa, the classic Histoplasma capsulatum variant capsulatum coexists with the variant Du Boisi. The yeast form of the latter is much larger and has a thicker wall. The mycelial forms of it, really, you can't distinguish between variant capsulatum versus variant Du Boisi. The gist of it is that for African histoplasmosis caused by the variant Du Boisi, skin and skeleton are the most frequent organs affected by the pathogen. And here is where you can have cutaneous inoculation as an alternative mode of acquisition of the infection. So for skin, you have your ulcers, nodules, or psoriatic-like lesions. They can spontaneously resolve. You also have, if your subcutaneous tissue is involved, you can have tender nodules or cold abscesses, in which the typical manifestations of inflammation are absent. And then for the skeleton or your bone lesions, so they are osteolytic bone lesions, and usually it's the skull and ribs that are the most frequent bones affected, followed by your vertebrae. And histopathologically, you will see a granulomatous inflammation within the bone. And actually, this can even lead to sinus formation and cystic bone lesions. And it's not uncommon to have multiple bones affected. So for diagnosis for histoplasmosis, there are many different ways to really diagnose it. One is clinical, but adding your lab work to that, there's fungal culture. And when you do want to grow histoplasma in culture, you need to use brain-heart infusion agar. You may need to use antibiotics or and cycloheximide, especially if you're trying to culture out of specimens that are not sterile, like your sputum. And then after that, that's incubated at 30 degrees Celsius for up to 6 weeks. The con is that the incidence of positive cultures really varies considerably. One, depending on the burden of infection, the source of the infection, and how many specimens you collect. The other thing is that it takes a long time. So in patients, fungal cultures will be positive. They should be positive. Most of them will be positive in, by 3 weeks. But again, you have that whole 6 weeks to wait if they're, to see if histoplasma grows. But 3 weeks, in a patient who's, say, has a severe histoplasmosis infection is something that, you don't have time to wait for that. So I wouldn't, really, while it's gold standard for the diagnosis, actually growing the pathogen, clinically, it might be too late, to be of use, especially in an ill patient or a critical patient. And then you have your antigen detection. So you can detect a polysaccharide antigen in the serum or urine by ELISA. And in patients with moderate to severe acute pulmonary histoplasmosis, antigen testing of the urine and serum yielded a detection rate of approximately 80%. So the sensitivity is fairly good. It can actually also be used to monitor response to therapy. The downside to it is that you can have cross-reactivity with other kinds of endemic mycoses, like your blastomyces, coccidioides and paracoccidioides. So antigen detection, great sensitivity, but specificity, leaves some to be desired. And then you have your serology. So there's two ways. One is through complement fixing antibodies and then through precipitin bands or immunodiffusion. And they have been the most common tests used in the clinical laboratory. A major limitation of the serologic test is that even in the presence of active infection, they can be negative in up to 50% of your immunosuppressed patients, especially those with AIDS. So that's a big drawback to your serologic testing. So the first kind, let's again, complement fixation as part is a kind of your serologic testing, and really a titer of 1:8 to either yeast or mycelial antigen is positive. If you have a titer of 1:32, then you really would be suspicious, a possible diagnosis of histoplasmosis. Values in between though neither exclude nor suggest diagnosis. So say for acute histoplasmosis, how your complement fixation test would look like would be that there would be a 4-fold or greater rise in your CF titer between acute and convalescent serum. And while you have proof that your patient had truly acute histoplasmosis, by that time it'd be too late to be of value to patient management. A drawback to complement fixation is that I'm from an area, or I practice in an area here in central Illinois where we are endemic for histoplasma. And so low levels of CF antibodies can actually be detected in 10% of individuals from endemic areas. So, if I had a patient who had a possible CF antibody, then that's something you would have to really take into consideration, is that this could be just because my patient is from an endemic area and not much other than that. By 6 weeks, at least 75% of patients with acute histoplasmosis will manifest a positive CF antibody titer or 4-fold rise. But over the course of months, the antibody titer will decline, but it may remain serofast for years, especially those who have the cavitary pulmonary disease or chronic PDH. It's 70% sensitive for acute infection, 80 to 95% for chronic disease. Again, the false positive rate of 15% can be seen. There is cross-reactivity with coccidioidomycosis or with blastomycosis. So complement fixation, the gist of it is that good sensitivity, but the specificity not very good. Compare that to immunodiffusion, or you looking at your precipitin bands M and H. So how you run this test is that on the agar gel precipitin test, these bands are identified by lines of identity, with bands formed by control serum known to have precipitating antibody to H or M antigen. So your H antigen is homologous to your beta glucosidase and the M antigen to the catalase. And those two are proteins released by mycelial and yeast phase cultures. Antibody to H antigen is very infrequently detected, so less than 10% of the time, but when that is positive, then that signifies active infection. Antibody to your M antigen, though, is detected in up to 80% of individuals following exposure to the fungus, and therefore really not very useful in discriminating remote from current or active infection. So comparing immunodiffusion to your complement fixation, your immunodiffusion is specific, but really not sensitive. And then you have your histochemical identification. So when you're trying to say you get a bone biopsy, you want to get a smear of that and look at that under the microscope. You want to stain it with either a Gomorian methenamine stain or the Grocott silver stain to best visualize that. The H&E stain or hematoxylin and eosin stain isn't very good at visualizing, these things. Smears may be diagnostic, they're also fairly rapid. So if your smear is positive and you can clearly see these small yeasts with narrow-based buds, then great, you have your diagnosis there. You'll see also yeasts within macrophages. Skin testing is another kind of you could diagnostic modality, but really it does not help identify acute infection. In endemic areas, you'll have more than the 70% positivity. So again, not a very good test. And then you also have your beta-D-glucan assay, or the Fungitel test. And that has a fairly good sensitivity to close to 90%, but specificity on account of the cross-reactivity with other endemic mycoses, the specificity really isn't very good. Diagnostics for histoplasmosis really, this is a nice table from Mundell, looking into how and what essentially you would want to consider ordering for the kind of infection and severity of infection that you are suspicious of your patient having. And then we'll go through the clinical practice guidelines. This needs to be updated soon though, because it was released back in 2007. So, almost 15 years ago. And really they have this very nice table that have the indications for antifungal therapy. So you have a definite indication for antifungal therapy. That's really with acute diffuse pulmonary infection with moderate to severe symptoms, chronic cavitary pulmonary infection, progressive disseminated infection, and CNS infection. Those that that do not have any indications for antifungal therapy include your mediastinal fibrosis, pulmonary nodule, broncholithiasis, and presumed ocular histoplasmosis. So before we go through the tables from the guidelines in regards to antifungal therapy, really I just wanted to show that we don't really have a lot of options for antifungal therapy. Really, it's either your amphotericin B or your azoles, because echinocandins have no role in histoplasmosis therapy. For your amphotericin B, you usually really use that for severe pulmonary or disseminated histoplasmosis. They actually found in a clinical trial that in those with AIDS and progressive disseminated histoplasmosis, that liposomal amphotericin B had higher response rates and lower mortality rates compared to those who were treated with amphotericin B deoxycholate. But either of those, if your patient has relatively low risk for nephrotoxicity, it won't be wrong to use amphotericin deoxycholate. And then you have your azole class. The gripe of every infectious disease doctor with your azoles is that it's a CYP450 inhibitor. So we always have to be very cautious for drug-drug interactions. Among the azoles, really the number one that you will use to treat histoplasma is itraconazole. And that's really the mainstay of treatment for mild to moderate disease. And it's the one that's used as step-down therapy after the initial response to amphotericin B. When the guidelines were released, we only had either the itraconazole solution or the itraconazole capsule. So the solution form of itraconazole actually was preferred on account of it enabled you to get higher levels compared to capsules. And once you start itraconazole therapy, you should get a level of your itraconazole 2 weeks after to ensure adequate drug exposure with your goal serum level of being more than 1. But most recently, and I think maybe it was just in the last few years, we now have the extended release form of itraconazole, which, itraconazole, usually even the capsule, you take BID or twice a day, but the extended release is just a once a day formulation. And that actually, at least, is actually same, if not a little bit better compared to the itraconazole solution in terms of your patient getting higher levels or more therapeutic levels of your itraconazole. So if the drawback though is that it is expensive, so not a lot of insurance companies will unfortunately approve an extended release formulation. And the other azoles that do have in vitro activity against histoplasma include your voriconazole, posaconazole, and isobuconazole. Isobuconazole, in studies, it does show that it has activity against histoplasma, and there have been reports of it being successfully used in the treatment of histoplasmosis, but it would still be an off-label indication because it's not FDA approved for that yet. And then fluconazole really has been used successfully for treatment, but it is much less effective than itraconazole. And in patients who have had who have failed therapy, they have actually seen fluconazole resistance. And usually the fluconazole dose that you would need, kind of an induction therapy, would be very high dose, like 800 milligrams per day, which brings into light the drug, not just the drug-drug interaction, the QTC prolongation, kind of side effects, but tolerability as well might not be as good. That along with, again, its inferior therapy compared to itraconazole. So again, among the azoles, itraconazole is number one. Fluconazole would not be a recommendation, not unless you didn't have any other choice. And again, echinocandins have no role in histoplasmosis therapy. So this is a nice table from the 2007 guidelines, and it shows you, based on the kind or the manifestation of histoplasmosis disease, what treatment to use and for how long. So if you have severe acute pulmonary histoplasmosis, you would get a lipid, you could get liposomal amphotericin B or amphotericin deoxycholate for 1 to 2 weeks, followed by itraconazole for a total of 12 weeks, with or without methylprednisolone. But methylprednisolone, the effectiveness of that is not very well tolerated, not very well documented. And then for mild to moderate acute pulmonary histoplasmosis, if they have symptoms of less than 4 weeks, that does not need treatment. But if they are symptomatic and it's been more than 4 weeks, you can treat with itraconazole for 6 to 12 weeks. And then you have your chronic cavitary pulmonary histoplasmosis that's treated with itraconazole for at least 12 months. The thing that we worry about here is that in chronic cavitary pulmonary histoplasmosis, relapse can occur in about 15% of cases, even with adequate treatment. For pericarditis, that's moderately severe to severe, you can treat with itraconazole only if prednisone is used. And you can use that for 6 to 12 weeks with prednisone and tapering doses over 1 to 2 weeks. And if there is tamponade that necessitates drainage of your pericardial fluid, antifungal therapy really is given only to reduce the possible dissemination caused by your prednisone-induced immunosuppression. For mild pericarditis, really the thing you give them is NSAIDs. No need, or there is no indication for treatment with antifungal agents for mild pericarditis. For rheumatologic histoplasmosis, is really just NSAIDs. Corticosteroids are rarely needed and no antifungal therapy is indicated. For mediastinal lymphadenitis, It'll depend. So if they have mild symptoms, less than 4 weeks, no treatment that's needed. If they have symptoms warranting treatment with prednisone, then you will give prednisone with itraconazole for 6 to 12 weeks. And then non-steroidal anti-inflammatory agents may be given, but really the effectiveness is unknown. For mediastinal granulomas, and if they're asymptomatic, we don't need treatment. But if they're symptomatic, so much so that surgery may be even required to relieve obstruction, you may need to give them itraconazole for 6 to 12 weeks. For mediastinal fibrosis, antifungal treatment is not indicated. If you have any obstructions, then stenting of your obstructed vessels will be useful with itraconazole for 6 to 12 weeks. So, and then for bronchiolithiasis, again, no need for treatment. Pulmonary nodules, you don't need to treat for, with antifungal agents, but the thing here is that you do need to differentiate that from malignancy, so a biopsy might be indicated. And then you have your progressive disseminated histoplasmosis. If it's moderately severe to severe, again, you start with your amphotericin B, either liposomal or deoxycholate for at least 1 to 2 weeks, followed by itraconazole for 12 months. If it's mild to moderate progressive disseminated histoplasmosis, then you can just go straight to itraconazole for 12 months. And if you have central nervous system histoplasmosis, again, you have your amphotericin B followed by itraconazole. So amphotericin B for 4 to 6 weeks, followed by itraconazole for 12 months. And then in the guidelines, they also mention prophylaxis for histoplasmosis, which we'll talk about in a little bit. Other considerations. So if you have a pregnant lady who was very unfortunate enough to have histoplasmosis, you cannot use your itraconazole. So because azoles exhibit teratogenicity. But histoplasmosis in pregnancy, there is really a risk of transplacental transmission to the fetus, which can be prevented by the administration of antifungal therapy prior to delivery. But the antifungal therapy of choice would be amphotericin B. Even the liposomal amphotericin is safe for pregnancy. And then there is going to be a need. So once the patient has delivered, there will be a need to examine the placenta histopathologically for any granuloma or for organisms resembling histoplasma. And then if they are positive, then need to do some testing and monitor the child or the neonate for histoplasmosis. And then for histoplasmosis in children, really the treatment indications and regimens are similar to those for adults, except that they do recommend amphotericin B deoxycholate more than they do the lipid form. And that usually has to do with the tolerability of the deoxycholate over the lipid form. And the deoxycholate doses is smaller. It's 1 mg/kg per day compared to adults. And then for prevention, so there's the issue of, do we give prophylaxis to immunocompromised persons? But when we do it with itraconazole 200 milligrams once per day. It is recommended in those with HIV and CD4 of less than 150, especially if they live in areas where histoplasmosis is endemic and there are more than 10 cases per 100 patient years. It is also recommended in solid organ transplant recipients or patients who are scheduled to receive TNF-alpha inhibitor therapy, or those with hematological malignancy scheduled to undergo chemotherapy who have recovered from active histoplasmosis infection with or without treatment during the past 2 years. So if they're fairly immunosuppressed, so if you have a non-HIV patient who's fairly immunosuppressed because of solid organ transplant, hematologic malignancy, on chemotherapy, if they're on TNF-alpha inhibitors and they have had active histoplasmosis in the last 2 years, then prophylaxis would be, secondary prophylaxis would be recommended. And in the guidelines, they actually, they defined active histoplasmosis as having, positive for antigenuria, having a CF titer of more than or equal to 1:32, having had a recent pulmonary illness with radiographic imaging findings consistent with histoplasmosis without a clear diagnosis. So if there's even this, even if not diagnosed officially as histoplasmosis, but they do look like, at least clinically, as having had histoplasmosis, and they are immunocompromised, then yeah, those patients should get prophylaxis. Serologic screening for histoplasmosis, though, is not routinely recommended for patients in endemic areas prior to solid organ transplant, stem cell transplant, or use of TNF-alpha inhibitors due to the low reactivation rate. Actually, post-transplant histoplasmosis is uncommon, with an incidence of less than or equal to 1%, and is much rarer, especially in those who are hematopoietic cell transplant recipients. So, really routine screening for histoplasma with the intention for prophylaxis, even in endemic areas, it's really not recommended. Another way really to prevent is through educational efforts aimed at those who work in areas in which a substantial risk of infection exists. So, say you have people who work in rehabilitating buildings with, that used to have or house bats or birds, then you must educate them that, hey, practice dust control, use N95 masks when you are working. Back in the day, there were, they used to do formaldehyde decontamination in old buildings, but really that fell out of favor on account of the vapor is toxic. It can seep into groundwater, and it does not penetrate dried guano uniformly. And so there is no vaccine against histoplasmosis. Really, all that we can do is for immunocompromised persons to, one, stay away and limit their exposure to soil or bird droppings or bat guano. Give prophylaxis to those who meet criteria for it, and for those who expose themselves, because of work or recreational activities that expose themselves to high, to histoplasma, that fungus, then they should be wearing, appropriate gear. So take-home point: histoplasmosis is endemic, in parts of the U.S., but it can also be seen worldwide. It exhibits a spectrum of disease. Most infections are still asymptomatic, but if you have the right immunocompromised host for it, you can have, you can also have a severe and fatal disease. Amphotericin B, you use that for severe infections or disseminated infections. For mild to moderate disease or as a step-down therapy after amphotericin therapy, you use itraconazole. And then for prophylaxis with itraconazole can be considered in those with AIDS or in immunocompromised individuals who have had active histoplasmosis in the last 2 years. There is no vaccine against histoplasmosis, just wear your mask and prevent exposure. That's the end of my lecture. I'm open to any questions if there are any.
Perfect. Thank you so much, Dr. Chua. Yes, like I said, if you have any questions, you can put them in the chat. All right. I guess a couple more seconds, but if not, in advance, thank you all for coming out, and thank you, Dr. Chua, for your time and giving this presentation. There was a lot of good information that even I took away, so thank you for that.
All right. I appreciate it was my pleasure to participate too.
Okay.
All right.
Okay, sounds good. All right. Hi. Goodbye, everyone, and have a good week.
Bye.
Bye, Dr. Chua. Thanks.